A lot of people who come to see me have never had a health concern ever in their life, and through no fault of their own, they've suddenly got stage 4 endometriosis, and they're having to have this really difficult discussion about major surgery. And it could be as young as being in your early 20s, when all your friends are going out, on holidays and OEs, and you're having to have a talk about a potential bowel resection. And so it can be a really overwhelming time for people, but equally it can also help people tremendously.
Totally, and equally it can be that thing that they go, finally, I've got an answer for why I've been struggling with this, and not just period pain but fatigue, and there's a way through, there's a plan for me. I think that would give a lot of people just a lot of peace knowing that there's a plan for them. Hello and welcome to PCOS Explained, formerly the PCOS Nutritionist Podcast. I'm your host, Clare Goodwin, a registered nutritionist and exercise scientist, specialising in PCOS because I have it too. Each week we'll uncover the latest research, share inspiring stories, and provide practical tips to help you thrive with PCOS. Whether you're newly diagnosed, you've been struggling with this for a long time, or supporting someone with PCOS, this podcast is your go-to resource for empowerment, education, and community. So join us as we uncover the tools to thrive with PCOS. PCOS Explained is brought to you by our very own service, Ovi. Ovi is your go-to health service for women with PCOS. We help you improve your PCOS symptoms and prevent the long-term complications of PCOS by giving you hyper-personalised health advice based on your specific symptoms and PCOS drivers. We have a range of plans to suit your needs, from a DIY app-based program to one-on-one consultations. You choose what suits your budget and learning preference. And we offer a result-based guarantee on our Premium Plus plan, meaning that if we don't help you achieve your goal, we refund your money. Ovi is available worldwide, so it doesn't matter whether you're based in the UK, US, Canada, Australia, New Zealand, or anywhere else, we can still help you. So today on the podcast, I'm interviewing my dear friend, Dr. Praveen De Silva. Praveen and I met at Otago University, where we were both studying, and that's where he studied medicine, and then went on to specialise in obstetrics and gynaecology, and then further specialise in gynaecology and specialist gynaecology surgery in endometriosis. So this is why I wanted him to come onto the podcast today, to explain to you all about what endometriosis surgery entails, how to get diagnosed with endometriosis, what are some of those symptoms, and then if you have been diagnosed with endometriosis, what are the treatment options available to you, including surgery. So Praveen, so great to see you.
Yeah,
very
lovely. Nice
to have you in here. Can you tell us a bit about how you got into specialising in endometriosis surgery?
Yeah, it's interesting. A lot of people ask me this, because I guess very similar to the work that you do, Claire, we were just talking before we started that it's quite a niche area, and I think that there's positives and negatives sometimes with having a niche area. I enjoy it because I get to see people with very specific symptoms and issues, but I can also be very effective with helping people specific to that area. I trained in New Zealand and then a little bit in Australia, which I'm happy to talk about. So I'm kind of a kind of Australasian trainee. Started my life in Dunedin doing medical school there, as you know, and
so we were neighbours in our first year at our hall of residence. So yes. Praveen and I live two doors away from each other.
We won't say what year it was.
Yeah.
That's giving away our age. I think we still look quite young.
Yeah.
But did my preliminary training there, did further medical school and kind of junior doctor years in Wellington. And for junior doctors, you start to decide what area of medicine you're interested in. And for me, it was always what we call obstetrics and gynaecology, or O&G for short. And I would say that the majority of people who choose O&G just want to deliver babies. Like, it's the babies that draw you into that field or specialization. I think when you're a bit younger, it's a real adrenaline rush. You're happy to be up all the time at night. And that obviously gradually changes. But we do training for 6 years to become an O&G specialist. And the really nice thing about that particular specialty is that there's a lot of niche areas that span off O&G. So you do have doctors who are generalists who do a bit of all O&G. And then you have people who go specifically into fertility, into gynecology, cancer, which is obviously a very intense area of medicine, people who look after women's prolapse and incontinence. And specific obstetric issues, and so kind of like that was when I first got the picture that there is actually this specific area where you can train in endometriosis and endometriosis treatment and surgery. And so by about year 6 of training, I suddenly thought that was something that I really wanted to get involved in, and then that's what took us to Sydney. So my wife and one child ventured over to Sydney to start training there. So this was after the 6 years, and I did another 2 years of training.
I just want to clarify that you didn't leave your other 2 children behind. This was
the
other two children
came later. We actually,
just in case anyone's looking at your Instagram and being like, you've got 3 children. What do you do with the others?
So yeah, we actually had one child in Sydney, and look, I think that outside of medicine, a lot of people like to go abroad, broaden your horizons, the experience of travel, working in a new health system. I think. Because you did a bit of overseas travel as well, didn't you?
Yeah, totally. I lived in London for many years, in Spain actually for a year as well. And I agree. I think it does, it helps you understand, especially in the health system, how, like I wasn't working in the health system then, this was when I was still in technology. So I was working for a company called Xero when I was in London. So they do cloud-based accounting software. But it does expose you to the way that different health systems work, and I think that it would be very interesting to see, especially coming from New Zealand, which is primarily a public health system, to Australia, which is a much more public-private kind of partnership system, and just how that works, and all the nuances of that, and then just all the context as well about, and that's always really helpful in health too, knowing who to go to when you've got a question, and get some outside experience, and then also seeing what is available outside your home country.
Yeah, Australia, like I really enjoyed my time over there. Obviously made really good friends and work colleagues. I think the benefits of going to Sydney was that it naturally is a bigger population than New Zealand, and again it got me that exposure to a lot of endometriosis cases, and obviously very specific types of endometriosis as well that we could talk about later.
Totally.
I think I saw that there were a few questions about that for later. And so it was fantastic. Worked with some extremely good doctors who I would say are world-class leading doctors in endometriosis and in surgery. But there was always the pull to kind of come back to New Zealand. So we obviously then had baby number 2. And interestingly, after I finished my training in Australia was when the COVID pandemic hit, and going into lockdown and all of that. And I think that was the final straw, thinking, look, we need to come back home. Obviously my extended family's all here. And then the opportunity to come to Auckland came up, so we did quarantine for 2 weeks with the 2 kids. I'm sure that some of your listeners will be able to relate to that. And I've been working in Auckland since 2021 now.
Brilliant.
So that's kind of my medical journey.
So can you start by explaining a bit about, what do we currently understand about what endometriosis is?
Yeah, look, endo has been known about for a long time in medicine. I think that the attention that we're giving to endo is a lot better than it was, say, 20 years ago. But what we do know about endometriosis is that it is an inflammatory condition that it starts inside the uterus, and the lining from the uterus spreads elsewhere in your body. And the body doesn't like that happening, and it starts to have an inflammatory response elsewhere. We always used to think that endometriosis started from endo coming out of the uterus through the fallopian tubes. But as we've progressed, we've learned it's a lot more complex than that. There are some genetic components to endo. Endo can spread through the blood system, through the lymphatic system. I often actually get some people coming to see me who have such a family history of endometriosis, or signs that people in the family have had endo. So they say, oh, my mum had a major surgery at 35 and no one knows why, or my auntie had her hysterectomy and her ovaries taken out many, many years ago, and you start to get that kind of picture. There are certain variants of endo that are more aggressive, which seem genetic based. Some people who have 3 or 4 sisters in the family have also had endometriosis. So there is a lot more that we're going to do in the future to kind of pinpoint why some people get it and some don't. But at the moment, we do know that it's an inflammatory related condition that affects 10% of people assigned female at birth.
When you said variant, what did you mean by that? Is this like on kind of like a spectrum of how severe it is? And you've mentioned about it there being different stages, like stage 1 to 4. Is that what you mean?
Yeah, I think that what we still don't quite understand is why do some people get mild spots of endometriosis that we call stage 1 and nothing else? And it might stay like that forever and not get any worse. And why do some people get horrific endo that invades their bowel, invades their bladder, invades their ovaries and their tubes? And it's a myth that if you leave stage 1 disease forever that it's going to get morph into stage 4. It doesn't always necessarily do that. So I think what we are learning is that there are different variants or different levels of aggression of endometriosis. In my personal experience, people who have an extensive family history or get endometriosis at a younger age tend to have more aggressive endometriosis.
Right.
But it's still a kind of a evolving area.
So it's true that not everyone develops endometriosis from a younger age, or it's just that it's not picked up? Is it that it can develop at different ages, or is it that literally you've had it but you didn't know?
Yeah, look, it can be both. So definitely there are some people who present later in life that have just put up with symptoms for so long, and they probably have had some endometriosis for a long, long time. Equally, I've seen some people who say to me, periods were always fine, got pregnant without any difficulty, and suddenly in my late 30s I'm getting this debilitating pain and fatigue and I don't know why. And it even perplexes me why some people get endometriosis later in life. You asked the question whether people post-menopause can get endometriosis. I think my answer to that is that some people can continue to be affected by endometriosis effects later in life. I have seen some people with adhesions or scarring from a long history of endometriosis that still lingers beyond 50 years of age. But primarily the people that I meet would be aged between 20 and 40.
Right.
That's the common age of people who get endometriosis symptoms.
And also those that, I was just thinking then, after talking about menopause, those that have had a hysterectomy.
Yeah, the hysterectomy topic comes up a lot.
Yeah.
I think what a hysterectomy is, Claire, is choosing to remove your uterus through a surgery, which is a permanent thing.
And so that's a partial hysterectomy, right? And full is when you remove the ovaries and the uterus.
Removing the uterus and the cervix is a hysterectomy, and then the tubes and ovaries, I guess you could say, is a full hysterectomy,
right,
which is very, very rare these days and often not advised.
Good.
And obviously,
I'm glad.
Yeah, it's
we recognise that like the ovaries and the hormones and like fucking important. Like, right?
Absolutely. And so, I think that's certainly kind of a last resort type surgery.
Right.
And we don't advise a hysterectomy to treat endometriosis. I think that you can have a surgery to remove endometriosis, and that can be a very good surgery. You will often hear of people with endo having a hysterectomy, and what I would say to that is that there are other reasons that push people into a hysterectomy, particularly heavy, difficult to manage periods, specifically where the pain is worst during the time of the period, can lead to considerations of a hysterectomy.
And that would make so much sense, right? Because it's like, well, the uterus is not the problem, it's the fact that the endometrial tissue is growing inside the rest of the body. That's the problem, right? Correct. So like just removing the uterus is not actually solving the issue.
Absolutely. And you must remember that it's a bigger surgery as well. So you really want to think carefully about whether that's for you. But that said, particularly people who have completed their family and period control is the most common reason, sometimes prolapse.
True.
It's that acknowledgement that endo is so widespread that people can have other issues on top of endo, and I see it every day. And so some people do choose to have a hysterectomy during endometriosis surgery, which I think is a valid point, valid right. And the similarities between endometriosis and PCOS are quite shocking in that sense.
Totally.
And it follows that same trajectory of the diagnosis and the prevalence.
Yeah. You're right. They're both kind of about 1 in 10. PCOS being a bit more like 1 in 8 now. They both can be really hard to diagnose for different reasons. And a lot of people actually ask, is there a crossover? Because, we seem to be getting more people with, I think that at the moment the stats still show that it's about 1 in 10 people with PCOS will also have endometriosis, and that's just reflective of the population, as you said. But who knows, we might find in the future that there is like some, because a lot of the things that we're going to talk about are very similar kind of underlying triggers or drivers or similarities with PCOS and endo too.
And I do think, like exactly what you said, Claire, that when you've got 10% of the population afflicted by this, there are overlaps. Unfortunately, you can be unlucky enough to have both, which I'm sure you've got many people that you look after who do fall into that category. So I guess the awareness is so much better. I am in full support of a lot of patient advocacy and patient support groups that draw attention to this condition, because it is hard to know where to get accurate information. So it is prevalent. It is something that our healthcare system in New Zealand does address. So obviously we're very resource constrained still. And so you know, doctors who work in primary care, GPs, will see people to talk about endometriosis as a possibility. Specialists, gynaecologists, particularly people with an interest in endometriosis like myself. Would this be a good time to talk a little bit about what makes people think about endometriosis? Or the most common symptoms that people exhibit or get that makes them worry about endo is pain. Fatigue is a close second. And I think that's one that's
interesting.
Not addressed and talked about enough.
No, I don't think so either. And similar with PCOS. Like very rarely people talk about the fatigue side. So what is it, what would you see in terms of patients presenting with fatigue? What does that feel like for them?
Yeah, so it can be very varied. And I think when we talk about what causes endo or what's going on inside people's bodies, it is an inflammatory condition. And inflammation simply means that things are angry, things are not happy. And the immune system gets in on the party with that. It realizes that things are not happy inside. And that can burn a lot of energy and make people feel very low and run down. It can be around the bladder or the bowel. So a lot of people that I meet get a lot of pain or even functional issues with passing urine or passing poo. So those are the common areas. But the more widespread endo is now, we are seeing people with endo in really strange places. I've seen a few people recently with endometriosis on the diaphragm. So the diaphragm is your muscle up here between your chest and your abdomen. And naturally that can cause some very debilitating symptoms with breathing, with certain exercises. If you go down the rabbit hole and delve deeper, you can find endometriosis in the pleural or chest cavity. There was one case study of someone who got cyclical or nosebleeds with their period.
Wow.
But just to wind it back a bit, it's a very, very rare situation. I would say that the common presentation of endometriosis is pelvic pain. And that's, I think, what people first present with. The question around what is normal pelvic pain and abnormal pelvic pain is one that I think a lot of people find really difficult, because a lot of women who first start menstruating or getting their periods, it is naturally going to have some level of pain associated with that. And I think what people find hardest to figure out is my pain abnormal? Is this too much pain? That's, I think, where the difficulty in the diagnosis lies. Like, when is it enough pain that you want to actually see someone about this?
Totally. And how common is it that you would, because I have a few patients that have been diagnosed when they're going through fertility treatment and they never knew, because they're like, well, I wouldn't actually say that I have period pain, you know, like it's not debilitating. I've never had to take a day off school or work. It's just, you know, so how common is it to not have like really severe pain? Yeah,
that's actually a really good point, Claire, in that there are people that we meet where they actually don't know that they have endometriosis, so they're what we call asymptomatic patients. And again, because it's so prevalent, because 1 in 10 have it, there are people who are existing quite happily without knowing that they have it. Sometimes the first time that people realize they have endometriosis is when they have trouble conceiving, so trouble getting pregnant. And that is a symptom as well, is difficulty conceiving or infertility associated with endo.
Yeah. What are some of the others? So we talked about symptoms of like period pain, fatigue, and we were saying that the fatigue is just because there's this chronic inflammation happening, right? And so when we talk about that, we mean that basically a lot of the resources that that your body would otherwise be using for energy are basically being put into constantly being in this kind of fighting state, right? And it's using up a lot of that. Is there sort of known triggers for that inflammation? Like I've heard of mention like STIs could be a potential trigger, but is there anything else known about maybe what could really trigger that?
Yeah, I think endometriosis is a chronic medical condition, and what a lot of people who see me find really hard is that it is a condition that's very hard to wipe out and get rid of, very much like PCOS. And that's not to say that you can't have a good quality of life. Exactly like what OV does is that you can modify certain things to improve the way that you live with endometriosis. And so I think that, to go back to your question about triggers, when things can get difficult or stressful in life, be it physical stress, be it mental or emotional stress, you can actually have altered immunity that then makes the endometriosis flare again. And a lot of people who suffer from endometriosis tell me this, that they have to come into hospital with endo flares, we call them, is that things were going okay and then suddenly, and sometimes they might not even know the reason why it happened, you can have this huge flare of pain for reasons unknown. And again, it can last for days, it can last for weeks. And there is a lot more research required to kind of pinpoint why does it behave like that. For a lot of people, it can be a very lifelong condition, endometriosis.
Yeah. So kind of the same as PCOS, where we say that it's like you can sort of reverse the symptoms or be a bit more sort of in remission or manage it. You're never going to be cured of it because it is an underlying, or in PCOS probably that genetic and also environmental epigenetic factors that are actually triggering the onset of PCOS. So like for me, I don't really have any symptoms at the moment, but if I went back to living like I was, 15 years ago, then I likely would develop those symptoms again. Is that similar to endo?
It's very similar, and there certainly are dietary modifications to help with symptoms of endometriosis. There are certainly lifestyle modifications, keeping a healthy weight, mindfulness. Some people use acupuncture, other treatments like that. There are people who can get cured from endometriosis, I must point out, which may be where it can be slightly different to PCOS, in that there are people who can have endometriosis removed who do actually have a complete resolution. Is that kind of similar to your? Yeah,
I think there is definitely, like with PCOS being that it's a syndrome, you kind of fall on the spectrum, and it could be that for some people you maybe get diagnosed, especially we see this coming out of like being on the hormonal contraceptive pill, and it may not have been sort of a real like chronic PCOS, but more of a temporary type of PCOS in terms of that they had, for example, a hormone called sex hormone binding globulin was high when they were on, because the pill was giving that to them, and so when they came off the pill, their natural levels were a lot lower, and so sex hormone binding globulin binds up to all your testosterone and therefore is what helps, not present symptoms. So if you don't have any of those sex hormone binding globulin or very little, then maybe your PCOS or testosterone symptoms will be higher. But that was more like a temporary state because you'd been on the pill. So there are definitely some, but I would say that it's much rarer to have that than what it is. And probably the same with endo, right? So much rarer to be cured after a surgery than what it is for that to be something that you're going to need to manage long term.
Yeah, I guess that segues quite nicely into what do we do when we think someone has endometriosis.
So how is it diagnosed?
Yeah, because it's such a constellation of symptoms and it affects a wide variety, it's difficult to diagnose. We now break it down to a clinical diagnosis and a surgical diagnosis. So in the olden days, they would say you have to have a surgery, you have to remove the endometriosis, you have to prove that it was endometriosis when it's checked in the lab. What we can now do, especially with the young age of people that present to us who might not want an operation straight away, is that we can say, look, it is highly suggestive that you have endometriosis. And that's based on the symptoms that you have. So the symptoms include pain, bladder and bowel dysfunction or pain associated, fatigue, difficulty with conceiving. And then also there can be signs. So signs are signs on a pelvic ultrasound that we can actually sometimes see endometriosis, and that obviously makes it much clearer. Sometimes an MRI, depending on kind of our level of concern. And so some people do benefit from knowing that you have a clinical diagnosis. It's highly likely, but we can still initiate some non-surgical treatments to help with that. And I think that there's definitely a paradigm shift now that it's not immediately a surgery. You can actually do things before that.
That is a big paradigm shift.
Medication obviously is helpful. Sometimes lifestyle changes, very much like PCOS, even though very advantageous, it's not enough, and you do need to start to rely on medication, which is always tough for people. Pain relief, particularly with triggers. So for some people, pain can be happening around the time of their period. It can be during exercise, during sex, which is really tough, and it's not always easy in the moment to decide that you need to go and take pain relief.
Or even effective.
Yeah.
You know, because it often doesn't work instantaneously, right?
Correct. But pain relief it's good to have a plan or a regime or a way to address pain. Hormonal medication is useful for some people. It's not a complete game changer for everyone. I would say that probably 1 in 3 people don't get a great effect from hormonal medication.
What do you mean by that? Like the Mirena or micronized progesterone?
So there's a lot of different types of hormonal medications that people can take for endometriosis. Essentially, our research shows that progesterone has an anti-inflammatory effect on endometriosis or endometriosis deposits. And I remember one of our professors at med school saying that finding the right hormone is kind of like finding the right shoe to fit you. For some people, the Mirena works brilliantly. Other people hate it with a passion. For some people, taking a birth control pill with progesterone in it is great. Other people can't remember to take the pill, so it's not for them.
Or it has the estrogen part of it has mental health implications, or there's a reason that doesn't work for them, or for some people it works brilliantly.
Yeah, and the depot, which the injection is the other way. And exactly what you said, Claire, is that for some people the side effects of hormonal medication is just too much. I think the toughest patients to look after are the ones where the hormonal medication helps a bit with the endo pain, but then the side effects are too much. And I had one patient recently who came to see me and she said, look, it has helped with the pain, but I just feel so flat on the hormonal medication that I just don't think I can keep taking it. Yeah. And that's such a tough place to be in, right? Because you are actually getting an improvement, but you just can't see how you're going to continue doing that. Yeah. And I think a lot of feedback that I get from some patients is that they've been to a doctor who's pushed the hormonal thing a bit too hard. And what I do when I see someone is I say, here's an option for you to try. I do think that if you're going to give it a try, you should give it a 3-month try. That's generally about the time frame that you need to know whether it's helping you or not.
And I think that's good sage advice for pretty much anything. Same thing, we say that with a lot of lifestyle treatment stuff as well, is that you likely don't see the effects for 3 months or so. So I think that's sage advice for a lot of a lot of that as well.
But I think I do respect that some people come back to me and say it's not for them, and that's also fine. Surgery is probably a big topic that I think a lot of people who responded to you wanted to have a bit of a talk about.
Yeah, definitely. And that's what I think what's come through really well is that it's not essential for diagnosis. Yep. Is that correct? So you can have that clinical kind of diagnosis. Is there a part to play though where they might not necessarily meet that clinical diagnosis, but there's still some underlying feeling that it could be endo, and therefore there needs to be surgery to kind of confirm that? Is that still quite common for a lot of people?
Yeah, I would agree with that, and I think that that's still a very important reason to have a surgery. I think what I've noticed is that decision happens further down the track now to maybe what happened 10 years ago. Right. So to clarify, a lot of people do choose to have a surgery to look for endometriosis once they've not reached a conclusion or once the current treatments are not working. To talk a little bit about there's a lot of people probably are wondering, what are they talking about? What is surgery?
Yeah, totally. And that is, I think that's a great segue into the next thing. What is it? Why would someone go down the route of surgery? Does everybody need it? I mean, it doesn't sound like that is the case for me. So how would you know what the different types are? What do I need?
Yeah, so primarily I would say now that the gold standard for surgery for endometriosis is to do what's called keyhole surgery or camera surgery. And I think that you should, I always try to avoid strong statements, but I think if someone's not offering you a camera surgery, you should probably consider getting a second opinion. Yeah,
running a mile to a second opinion.
So camera surgery can be either what we call laparoscopy, which is where a camera's put in, usually through the belly button. In a lot of countries now, they also have robotic surgery, which I think we're talking about beforehand.
I saw a great video that you put up of you doing this in Sydney.
Yeah,
super cool.
It's a newer technology, but it's an acceptable technology. It's been proved to be equivalent to laparoscopy. May even have some benefits as the technology evolves.
How do the two differ? Like what do they look?
Both are a camera being put inside someone's abdomen area to look for endo. With a laparoscopy, the surgeon is holding the camera themselves.
Right.
With robotic surgery, the camera is being controlled by a robot, but the surgeon is sitting right next to the patient in the same theatre, controlling the camera. So they're both very, very similar. Usually, and I think again people would be quite interested to know about surgery and the details. It's a 1 centimetre incision on your belly button where the camera's put in, so not a huge incision, and then that's where we take the pictures to see whether someone has endometriosis.
Right.
What I would say is that endometriosis is generally quite easy to spot as long as the surgeon doing the surgery knows how to spot endometriosis. It's kind of like a Where's Wally, the Where's Wally books. It shows up like these little black spots. It can be very subtle, can be very small, and we do a full 360-degree look around someone's abdomen to look for endometriosis, so to make sure the diaphragm, stomach area, the intestines do not have endo on it. And we usually try to take really good photos. In some situations I've been requested to take videos to show the patient what we found.
So what does surgery actually look like? So you talked about the keyhole, the 1 centimetre incision through the belly button and sending the camera in, but what happens in the surgery and what happens after the surgery? How long does it take to recover? What are we talking there?
Yeah, look, it's a major surgery, so it has to be done in a hospital and an operating theatre, of course, and I'm sure your listeners will be glad to know that you're fully knocked out. It's not like kind of when you pull out a tooth and they say, "Oh, would you like to be awake for it or not?"
I had a colonoscopy the other day because we've got a really strong family history of bowel cancer.
Yeah.
And it was quite strange because you're only sedated for that.
Yeah.
It was a very surreal experience.
Yeah. So just to reassure the audience, run a mile if you're not being put to sleep for endometriosis surgery, but you should be and you will be. So that's good. So you won't have any recollection of the surgery. It is obviously a common thing that a lot of people have to undergo, even at a young age. And laparoscopic surgery or keyhole surgery is a relatively safe thing to do. So the risk of complications is very, very rare, but still existent. Surgery often takes about 60 to 90 minutes. And what I say to people who are having mild endometriosis surgery is it's kind of like getting your appendix taken out. And I think some people have had that as a child and will remember what it feels like. Common feedback I've got from people after the surgery is that the gas pain's quite disconcerting. So when we do keyhole surgery, we put gas into your tummy. And the reason for that is that it separates out all the structures, which makes the surgery a lot safer. But the gas pain afterwards can be felt as high up as your shoulders. And it's so strange, I find, because some people do not get it at all. And I've kind of almost oversold it at the beginning, and then they said, I don't know what you were worried about. And then other people, the gas pain's the worst part, so it's very variable. The surgery itself will require good pain relief for at least 2 or 3 days afterwards. But the benefit of keyhole surgery is that the next day you're expected to they get you up and walking, you can have a shower, you're back on your feet quite quickly because there's small cuts. For people having this surgery, it's a busy time of their lives. They're studying, they're working, they might have children. I think the people who see me who have children, I always feel sorry for them, and I kind of try to let them stay a bit longer because you just know that they're going home to
I was going to say, all these things sound very similar to a cesarean section.
Yeah, exactly. So it is that level of surgery, unfortunately. That said, most people feel like they're returning to their normal selves within a fortnight.
That's good.
Most people feel that they can return to their normal jobs within 2 weeks, 3 weeks. There are, of course, exceptions to the rules both ways. Some people have said to me, I was, out walking the dog a week later and I felt fine. And then other people said to me, look, it actually took 2 months to feel normal again. So it is a bit of a varied thing. So it can be as simple as just a mild endometriosis surgery all the way to requiring bowel or bladder surgery. And naturally, if it's that level of surgery, it's going to take a bit longer to recover from. I do find it a very involved conversation with patients before surgery, talking about what it could look like, because the nature of the disease is sometimes you go into a situation where it is actually a lot worse than you realized and they have to have more surgery. And so I think just setting expectations is important for people before surgery.
Yeah.
How long does it take to realize the benefit of the surgery? Like, has it actually been helpful? I think it's kind of once the recovery's occurred. So most people say to me, oh yeah, it took a couple of months to feel better, but now I'm actually realizing that I actually do feel a lot better. Some people, their first period is really intense after surgery because naturally things are healing inside. And if periods are sore to begin with, and that can be quite disconcerting because you're having the surgery to make period pain better, and then your first period after the surgery is terrible, and you kind of ring up the surgeon saying, "What have you done?" But no, it does get better for a lot of people after that.
Yeah, I think it's good to have that expectation though that it might be worse.
Yeah,
and to know that can be that is likely normal. Is nice. As hard as that would be, it's a good expectation to have, that not thinking that I'm abnormal and actually the surgery's made me worse.
And it's, I think also, prepping for surgery is really helpful. So I think people who try and get things set up for the operation tend to do better. So obviously it's really hard to manage workload and, tasks that are going on at work. So like getting that sick leave sorted, your doctor can help you with a sick note for that. And you deserve to have some sick leave if you're having this type of surgery. Obviously we laughed about children, but having some help. We have single mums having to have surgery, and, get some friends or some family who can drop off meals and help with things like that. Mm-hmm. Having a bit of a plan for who to call if things are not going well. It's good that the GP knows that you're having an operation, so that if you are having issues afterwards, you know that you can go and see a doctor. Mm-hmm. But I think also you are within your rights to contact the hospital if you're not doing well after surgery, so that the surgeon knows.
Is there anything you shouldn't do? Like, I know, again, so much of the stuff is very, reminiscent of C-section stuff, so I'm like thinking about all the stuff that I was told you shouldn't really do in terms of like you shouldn't drive afterwards, or you shouldn't maybe lift heavy things or anything like that you shouldn't do post-surgery.
How long did it take you to kind of feel normal afterward?
I was really lucky. I was walking like that day, and then the next day I think I walked 300 metres up the road, and then by the end of the week I was like, I actually got my midwife to sign me off that I could drive after a week.
So you're probably the wrong person to ask.
I'm definitely the wrong person to ask. Like, I was on that extreme, but it's the same thing that you just said, is some people it just doesn't affect them as badly, or as other people it does, and it's not because I did anything right or wrong, it's just because that's the way that my body responded to the surgery.
And I think the benefits of keyhole surgery is that you do actually tend to feel normal quite quickly, and then there's that tricky thing of overdoing it.
I would say probably the same thing for me with a C-section. Yeah. I was like trying to be an overachiever in terms of my recovery.
I think if you want specific details, I think just be very careful about lifting or anything that kind of raises the pressure in your abdomen. So crouching down and standing up, just taking it quite easy for the first fortnight. I think that. But other than that, the sooner that you try to get back to normal life and normal activities, you're naturally mentally going to feel better as well. You don't want to feel like the patient all the time. There's no major restrictions on food or drink. I think that whatever can kind of go well with your regular system and body.
Would there be a risk though if you do err on like IBS in terms of bloating? After, would that be more painful, bloating?
Yeah, that's a good point actually. Some people, constipation can be a big problem after surgery because you've had pain meds which naturally constipate you. You're not moving around as much. So definitely be a little bit careful with what you put into your tummy until you know that your bowels are working again.
Totally. So maybe also some like magnesium oxide would be a really good supplement to take every night.
That is helpful, certainly, and some laxatives.
Yeah.
But I think that the majority of people are going to be quite happy a fortnight after surgery that they're on the road to recovery. And I'm in a lucky position that because of the types of people with endo, they tend to be younger people who are healthier with less medical conditions, and so they're naturally going to do well out of a surgery.
That's great to hear. I was going to say, so in terms of trying to find someone to work with on this, it would be really advantageous to find someone who's really specialised in this, right? Is there such thing as someone who's more of a general obs and gynae who would do this, or do the only people that do it are like yourself really specialised?
Yeah, look, I think in an ideal world you would want a gynaecologist who does endometriosis surgery a lot, and I always encourage people who are going down this track to ask those hard questions of a doctor, because you're taking on quite a risk having an operation, and I think you deserve to have some of those answers, like
Yeah, what would if you were me, and if you were talking to me and I was somewhere else in the world, you didn't know the specialist there, what questions would you tell me to ask them to make sure that they did know what they were doing?
I think mainly similar to pilots and other people who do a lot of procedural work, you would want to know that this person has been doing this for some time, and specifically asking the question of how many endometriosis cases do they do?
Right.
Because generally speaking, people who do more endometriosis surgery are going to be seeing it a lot more and treating a lot more. And it's very hard to find surgeons who can automatically solve stage 4 disease at the same surgery. And I don't think everyone around New Zealand would naturally be able to find that. But I think at least asking the question that a surgeon can recognize endometriosis, do they feel comfortable that they can? And do they feel comfortable that they can take biopsies to test for endometriosis if you're going through the surgical pathway? We have a lot of talk through patient advocacy groups about ablation versus excision of endometriosis. Have you come across those terms before?
I have, yes, yeah. But can you explain what they both mean?
Yeah, so ablation is burning the endometriosis when you see it, and excision is cutting out the endometriosis when you see it. It's very hard to prove the benefit in the literature, and medical literature and medical trials. They can be quite difficult to kind of retrospectively see who did what and what surgery. But what we do know now is that with deep endometriosis, it's kind of like roots in a tree going deep down into your body. And sometimes you can go and ablate or burn a spot of endometriosis and miss the roots that's growing underneath. So my preference always is to excise endometriosis. It's a lot more difficult to do that and requires more experience. So I think asking about that at a surgical appointment is helpful.
Yeah, so kind of what do you do? What is your preference? Is it ablation or excision? And then you can make your decision based off what they say.
And I think also asking what treatment will be done if endometriosis is found.
Right.
So some surgeons would say, I will be able to diagnose it today for you. And in some areas with limited resources, that's something that people will choose to accept. And then they may refer on for a second larger surgery later. And then some surgeons will say, I can treat and excise the endometriosis if it's found today.
Right.
So obviously...
Unless it's maybe, did you say stage 4 might not be? So if they came back and said, we found it, but it's stage 4, we can't do it now, would that be something that they could come back and say?
Yeah, absolutely. And I think that also goes nicely on to the risks of surgery. So surgery is very beneficial for some people. It can certainly help with a lot of the symptoms that people experience. The caveat with surgery is that sometimes it works and then endometriosis can grow back again. So that was something that we were going to talk about later. The risks of surgery is that you can get complications from surgery, and so that even in the best hands, complications still happen. Can be bleeding, can be a bad surgical infection, and at worst case scenario can be injuring something that the endometriosis is stuck to.
Right, so like perforating the bowel, which means basically poking a hole in the bowel, right, or something like that.
Poking a hole in the bowel, or more than that, is that if the endometriosis is truly stuck to the bowel, rather than it being a complication, it could be a necessity of the surgery. So if the bowel is growing if the endometriosis is growing into the bowel, there may be the need to remove that bad part of the bowel, which is actually therapeutic for the patient in the long run. But would you do it on the day when they weren't consented properly for that? Probably not. Yeah. And so the work that I get in my niche area is that I do get a lot of secondary referrals where people have found these problems either on MRI or at a previous surgery, and I'm having that conversation with the person saying, hey, look, this might be where we end up with the surgery today. It's probably once a week that I'm talking to someone about having to intentionally do some bowel surgery, which is really difficult.
Gosh, yeah.
I think for some, the thing that fascinates and draws me to endometriosis is that because it happens to people at such a young age, for some people, they have been healthy up until this point. A lot of people who come to see me have never had a health concern ever in their life. And through no fault of their own, they've suddenly got stage 4 endometriosis diagnosed, and they're having to have this really difficult discussion about major surgery. And it could be as young as being in your early 20s, when all your friends are going out, on holidays and OEs, and, you're having to have a talk about a potential bowel resection. And so it can be a really overwhelming time for people. But equally, it can also help people tremendously. So,
Totally. And equally, it can be that thing that they go, finally, I've got an answer for why I've been struggling with this, and not just period pain, but fatigue. And there's a way through. There's a plan for me, and I can, at least I think that would give a lot of people just a lot of peace knowing that there's a plan for them.
Yeah, I think surgery, it may not be for everyone, but in the right situations, it can be a very, very helpful thing. There is very, very good evidence that surgery for endometriosis helps with conceiving, with getting pregnant as well. So that's the other reason that people
how does
go
that
down
work?
there.
So would that only be if like the endometrial tissue was blocking a fallopian tube, or is there another mechanism by which this helps in terms of reduction of inflammation?
Yeah, you're asking all the right questions, and I think you're absolutely right. So blockage of the fallopian tube, which is preventing eggs from your ovaries getting to your uterus, is a problem. The inflammatory state of endometriosis can cause the inflammatory fluid to travel through the fallopian tubes into the uterus. And that affects the way that a pregnancy can kind of attach and thrive.
Right, so that would be like so even if there was no blockage in the fallopian tube, if that inflammatory fluid was travelling down the fallopian tube and into your uterus, like basically the fertilised egg wouldn't be able to implant in the uterus because it's just not a homely atmosphere for that.
That's right.
I always talk about it like, I was like, us females are like birds. We lay the egg and then we like in the nest and then we sit on it to incubate it, like we incubate it internally. And so it's basically that, like in this case, the egg's being released, it's getting to the nest, but the nest is just like, it's uninhabitable.
Needs some tidying up.
Totally. Yeah. It's like a few twigs. So it doesn't have any of the nice like feathers and moss and all the other stuff that the bird collects, right?
And then the other thing is the egg itself. So unfortunately for some people, they get endometriosis affecting the ovary, and that can affect the ability to ovulate.
Right.
And so that's also a very difficult situation to manage. When we're removing endometriosis from the ovary, we have to be very careful to remove the bad stuff, but actually keep the ovary intact and happy and healthy itself. But for all of those reasons, there are areas where removing endo can certainly help you to get pregnant. Again, it's it's deciding when to pull the trigger and do it for that reason, which can be challenging because, and again, where PCOS overlaps is that people are kind of deciding whether to embark down the fertility route of getting fertility treatment versus a surgical route of getting surgery for endometriosis, and that can be a bit of a balancing act, and it has to be individualized to the patient and what they're trying to achieve.
Right.
As a general rule, people who have terrible pain from their endo but also fertility issues, that's almost where you get real bang for buck with the surgery because you're trying to fix
both.
Two things.
Yeah. Is there any particular time frame whereby surgery would be more effective for fertility? Like I know, for example, with PCOS is that there's certain times where, I don't know, if you're doing like an ovarian wedge or something like that, then someone's going to have higher fertility in the immediate months after that. Is that similar for endometriosis surgery, where it might be that 3-month window or 6-month window after that you've got a higher chance, or is it that actually that you need a bit of healing time and therefore it's later that actually you have enhanced fertility?
Yeah, it's very, very similar. Interestingly, the research shows that the effects of removing endo can last for up to 2 years. Naturally, people are not ready to have sex and try for a pregnancy straight after endo surgery, and I feel that most people do take a couple of months out just to look after themselves, but I have known people to get pregnant after that time. The reason that we say that it lasts for 2 years is based on our research and evidence, but also that tends to be, if endo's going to stay away, it tends to stay away for a few years before it starts to reoccur.
Right.
And that can be varied in a lot of people, but you get a good 2-year window for most people out of surgery.
So how would someone know that they might need endo surgery again? So they might have had it in their early 20s.
Yeah.
What signs would indicate that you might need it again?
Yeah, look, it's a really difficult decision to even start the process to decide whether you see a gynaecologist again, start having the conversation about surgery again, because it's a really demoralizing feeling, right? To have had surgery, maybe to be doing quite well out of the surgery, get on with your life, and then suddenly you're kind of like, actually something's not feeling right again. And it's
or when you go to try and conceive and you haven't after maybe a few months, is there a time period there that you might think?
So absolutely, and I think for a lot of people who get recurrence of symptoms, it's not like an overnight problem. It's kind of just like any other chronic condition, it creeps up on you, and you might be really busy and not even realizing the symptoms because work's just flat out and everything else. And then you start to use your period tracker app and mark when it's painful, and a few months later you're thinking, gosh, it's actually more days that I'm in pain than I'm not in pain, or periods are getting worse and I'm needing more pain relief. And so it's kind of a very tricky thing to kind of get to the point where you're having to even entertain the thought of more surgery. I will say that I do see a lot of people who have to have a repeat surgery. And that doesn't mean that the first surgery was done badly or didn't go well, but it's just the nature of the disease that endometriosis grows back.
And I think that's a really important point to make, because I think a lot of people can feel that it is a failing on them, that especially when we're talking about that there are maybe some things that can be done to, like lifestyle changes or maybe medications that you can take, and it can often be one of those things where you then are second guessing yourself and being like, well, the pill made me feel like crap, but if I'd taken it, would that have meant that I didn't have to do this surgery again? And so it can be such a hard thing that you're then second guessing your lifestyle choices or your medication choices. And I think that it's just nice to hear that actually likelihood is there was nothing you could have done. Like this was the way that the disease was going to progress in you, and therefore this is unfortunately just a inevitable thing.
Yeah, and I think you are right. Like there is a feeling of that they, that somewhat it's on them, but it's not. Equally, on a positive note, I get some people who look at surgery as a very kind of positive, not spring clean, but just a sort out, and they got a good result from the first surgery. They got 3-4 years out of it, and they think, look, I know that it's a risky thing and a time-consuming thing, but I want to do it again to improve my quality of life. Repeat surgery can be done. Again, I would stress even more that repeat surgeries are done by people with good experience, because it can be more challenging. You can get something called adhesions. I don't know, have you heard of that?
I've heard of them. I can imagine things sticking together, right?
Yeah,
adhesions.
That's exactly what it is.
Yeah.
Just like the way that anywhere on your body, if you get a scar, it might not heal back completely normal. And the skin on your inside of the body, which is where the endometriosis grows, is exactly the same. If it's been cut before, it can look a little bit different. It might not be removed as easily. So I think people who have repeat surgery should really ask those questions of surgeons.
Right.
Yeah.
So the question you would ask then in that case is, have you dealt with second or third time surgery before? Right, like what's your history here? Yeah. Have you dealt with other questions like how would you handle an adhesion, or how would you, what exact question would you ask them to ascertain their comfort or experience in this area?
Yeah, look, I think that those are all good questions. And I think what we didn't even bring up having your first surgery is do your homework. So the patient should do their homework, like we already talked about, but the surgeon should also do their homework. So if I'm doing a repeat surgery, you don't want to go in blind. You want to really know what's going on. Imaging is really important. So the imaging options that we have is either an ultrasound scan or sometimes an MRI.
So an ultrasound, what, a transvaginal, so like it's going into your vagina as opposed to being an external on your belly one?
We try to kind of individualize it again.
Right.
Obviously, for a lot of people, transvaginal scans are really difficult to go through. I've had some patients who it's just not an option. So then we need to work with what we have, and a transabdominal or a scan over the tummy is the best thing. That said, the transvaginal scan is a better way of getting detail, because we're scanning really up close to where we expect the problems to be. And, we have options like a light sedation or pain relief, obviously having a person doing the scan that you can be a bit relaxed around. So we do try to use ways to help people get through a transvaginal scan, but that would probably be the mainstay of how we investigate. For some people with really serious endometriosis, where it is growing into the bowel or the bladder, an MRI might be better. Certainly, sometimes MRIs can show adhesions a bit better in certain areas. So I think doing your homework and knowing what you're getting into is really useful.
Totally. So if you were trying to figure out, is this surgeon going to be the right one for me? It's, have they asked me these questions about, like, okay, when was your last surgery? Maybe who did your last surgery? What did they ablate, or did they do the incision and removal. So they're asking all these good questions. They're then saying, right, next steps would need to get you and like as much information we can. So they're sending you for an ultrasound or an MRI. Those are all the steps that they should be, that would be giving you a good indication that this person knows what they're doing.
Yeah, I think that sounds like a very good plan. I think we're always cautious about online and social media. It can be a really useful adjunct, similar to TripAdvisor and things like that. People can get 5-star reviews and 1-star reviews outside of their control. But I think that there's some really good patient advocacy groups for endo, and sometimes talking to people who have had similar experiences is very useful pre-surgery. Some people have had good results with certain surgeons. Asking those questions of people who are living with the disease is useful. And the other thing I would say is not every doctor is right for every patient. And although I love what I do and I want to help, there are naturally going to be people who just don't gel with me, or I'm not the right fit for them. And I think it's really important when you're going through a surgery and you're going to be looked after post-operatively by this person, it's an ongoing journey. I would just encourage people to kind of just find someone that feels right for them. And there might be a particular type of doctor or a particular type of style that you look for. And, doctors are human as well. We all come with different personalities and different styles. And so I think find the right fit for you, but at the same time, like we said, ask those difficult questions of them, I think.
Totally. And part of finding that right person for you would be, maybe if they're not really engaging in those questions, might be a really good sign. And it's the same thing with, finding an obstetrician for you, or finding any, even if it was an orthopedic surgeon to do, if you just, as you said, if you just don't gel with them, or they're just not engaging in those questions that you're asking, then it's probably a good sign to seek a second opinion, talk to someone else.
Exactly. I think second opinions are fantastic. I get a lot of people coming for a second opinion, and I might see them again, or I might not see them again, and that's fine.
Same with me. Exactly the same as me. A lot of people will come through and have a call with me, and then decide that that's not the right thing. And I'll also openly tell them if I don't think that we're the right solution for them.
Yeah.
So I think it's a really good thing to. I think the hard thing is knowing. Okay, well, where do I find that other person? Especially in New Zealand health system, right, where you might be coming through a public health system. How do I ask for a second person?
It is difficult, and I think I do really feel for people navigating healthcare, and sometimes with the public health system as well, in that there are long wait times. You are within your rights to ask for a second opinion, and I think that's something that should be encouraged, and that's the way that New Zealand and Australia practice health. Your GPs are a good source of information for specialists who have certain areas of interest. They can also recommend people to see. Definitely, we are trying to work in New Zealand towards having dedicated doctors to look after people with endometriosis. And that is very difficult geographically because some towns are smaller than others. But there might come a time in the future where people get referred to other centres for endometriosis surgery.
Right.
And that's something that we're working on.
Because you do see people outside of Auckland, right?
Sometimes we do, yeah. Depending on severity.
Yeah. In the public system, how would you go about, so you say you've got your letter, you've been waiting on the wait list for 6 months, you finally got your letter to say that you've got an appointment with this specialist gynaecologist, and you go and you just don't feel the connection. Do you write to someone? Do you go back to your GP for a second? What's the process to...
Yeah, look, it's very variable depending on which hospital, but I think that, and it's hard because not everyone has a stable GP these days as well, and I get that, but I think that GPs should be the port of call for kind of your initial health concerns. But there is also an information or complaints process in every hospital that patients can access as well.
Yeah, which is funny, isn't it? Because you're I'm not necessarily complaining about them. I don't, it wasn't anything that they did bad. I just didn't gel with them. And it can be so hard sometimes, especially in New Zealand. And I'm very lucky that I get to experience through the eyes of my patients, all of the different healthcare systems globally, from Slovenia to, different states in the US, to the UK, to Australia. And I see great pros and cons of everything. But one con I definitely see in the New Zealand public health system is that while it is fantastic if you get hit by a bus or you've got an urgent case, sometimes chronic care is woefully poor. because you have to go through this process of waiting to see someone, and then you don't get to choose who you have that consult with. And then how do you go through that process of actually seeking that second opinion, or where do I go? Do I then go back to the wait list? And so it can be really tough for people to navigate that system and know kind of where to go. And that's why it can be really helpful talking to you and getting this guidance and feedback of going, okay, well, this is exactly the channel that I'd go down, these are the questions that I'd ask, because it's not easy to navigate it on your own.
It's very difficult. And I think, obviously we always want to better our system, and work needs to be done. And I think, having this kind of dialogue is helpful to hear from people experiencing the disease what's going on. But yeah. Totally.
And that's why it's great. We're not going to solve these in a day, but when you have these and you see, issues, you think, oh, great, we could fix this, but there's this part here we could just do. I mean, I'm already listening to you and being like, we could use the same, very similar thing that we use at the front end of OB, where we ask lots of clinical questions and we can then tell someone if they're, highly at risk of insulin resistance. We could do the same thing with the endometriosis questionnaire. Like, we could totally solve that.
And this is the thing, that's a good point as well, is that even though I am passionate about endo and I enjoy treating it, I'm one person, and endo, very much like PCOS, is a multidisciplinary team, and you cannot underestimate the effects that you can gain with other health professionals as well. So in the endometriosis sphere, we have physiotherapists that can help with particularly painful pelvic area situations where endo's flaring muscle spasms and pain. There's a particular muscle called the obturator internus that can get really affected by chronic pain. So there's work there, especially with bladder and bowel dysfunction, tricks to help with that. Nutrition, such a big area for endo. And then obviously we now have endometriosis nurse specialists as well. So there's a lot of work being done around the scenes for endometriosis pain specialists.
Yeah.
So, even though we have talked a lot about surgery today, I think that there are a lot of other people that fit into this.
Yeah.
And we just need to find a way to coordinate that in a really effective way, which work's being done, we're getting there, but that's kind of the future, in my opinion.
Yeah, totally. And I think that's really good to hear that, that kind of complementary therapy can happen as an alternative to surgery. For some people, they might not need surgery. That can happen prior, and then maybe they might need surgery later, or it can happen after. What is the research showing, or your clinical experience showing, that does that follow up with the complementary therapy? Does that then mean that someone might be at less risk of needing a follow-up surgery later, or delaying the time between when they might need that follow-up surgery, or delaying the time of needing surgery at all?
Yeah, I mean, I think we've discussed today, surgery is kind of there for situations where maybe nothing else is working. And I have to be honest, surgery doesn't fix everyone. There are some people who don't get a great result from surgery, a great relief from pain. But for those people who endometriosis becomes a long part of their life or a chronic problem, it's about using those complementary therapies to try and space out things, try and improve the symptoms.
Right.
And I think that research is very good for a reason, and I think it shows at a population level what helps. But for the individual, there are certain things that are always going to work well. I have one patient who loves getting acupuncture, and it works really well for them. And who am I to weigh in on that? If that helps that person, if there's an activity that you do, mindfulness, if there's something that you follow that helps with your symptoms, all power to that person. I think that's fantastic. And the day that I'm not needed is actually a big win as well, right?
Same here. Yeah, absolutely. And I think that's a really great way to look at it, because so many times in the health profession is that you can be like, well, that's not research backed. So, and you get a lot of times where a lot of people will say same thing in PCOS. It's like, oh, well, there's no research to support, or very limited research on, say, I don't know if it's acupuncture or something. And it's like, yeah, but as you said, we're so different. And research is kind of only as good as the population of people that you are looking into, and especially when it's complementary therapy, where it might be there's a combination of little things that you do that create that effect, not just one of them. So it wasn't just the acupuncture alone, it was the acupuncture and the mindfulness and the dietary changes, and that's really hard to prove in research, right? Where you're moving multiple needles.
And there's very few complementary therapies that interact in an adverse way with our conventional medicine. And I think that that's a stigma that's probably a bit unfair about complementary therapies, that because you do complementary therapies, you're not doing anything else. And it's actually very rare that I meet people like that. I meet people who, by all means, want my help, but they also have their own remedies that also might be culturally backed, and that's absolutely fine. I'm Sri Lankan originally, and I grew up with a big Sri Lankan family. I travel to India a lot as well, and just speaking from my own personal experiences, there are a lot of complementary therapies that people use in that part of the world, and there's very few things that are actually interacting with our conventional medicine. So I think you can have both, if that's important to you.
And finding what works for you. And sometimes it's not and it can be really frustrating listening to this and being like, well, just tell me the answer. And unfortunately, that's at the moment we probably don't have enough knowledge of why something might work for different people, and it can be a bit of a trial and error. But I think that's also empowering to know that there isn't just one thing. There are multiple things that can work for different people, and you could try it for 3 months and see if that makes a difference for you. And if it does, great, continue on. It's highly unlikely to be harming your health. That's what I say with when I maybe patients come to me and they say, I haven't actually been diagnosed with PCOS. Like, I don't know, but I've got these symptoms. And I'm like, well, let's give it a go, because it's not going to harm your health. And let's see if it can improve those symptoms. And if it does, brilliant. If it doesn't, let's leave it and move on to something else and see if something else improves your symptoms.
Yeah, absolutely.
So is there any kind of like words of wisdom that if you were sitting on the end of this, if you're listening to this podcast, you were struggling with period pain, you maybe hadn't been diagnosed with endo yet, or you have been, and you're looking at like whether maybe surgery is the right thing for you, for those two people, what would you do next? So you've got pain, but you haven't been diagnosed, and you have been diagnosed, but you don't know if surgery is the right thing for you. What would be the two next steps?
Yeah, look, I think for people who feel that the pain is out of keeping with normal, which is always so hard to know, I think finding people that you can talk to, that you trust about this, and sometimes it's asking a family member or talking to a GP. I think in our health system, a GP should be the first port of call for discussing the prospect of endometriosis. And most GPs, even if they don't have the training, will refer you on to someone who does a bit more of this at a primary care level. And I think that will start the pathway for investigating for a clinical or surgical diagnosis. And I think don't be afraid to access information, to look for patient advocacy groups. I think that they do provide an invaluable service to people who feel like they don't have that support. They sometimes, it can vary on the group, but they can sometimes be someone just to listen versus to refer you onto the right health resource or the right health practitioner as well. Those would be my first steps that I would suggest. And also know that you're not alone. Like we talked about it today, that 10% of the population are to some extent affected by this. That is not a small number. And don't be afraid to speak up if you think that you're one of the statistics. Yeah.
So just in terms of the pain thing, I think that a good guide, in my experience, just to say to someone is, if you've had to take any time off work or school because of the period pain, that would be enough for me to say, this is not normal.
Yeah.
Second thing would be if you've had to take anything more than kind of like a paracetamol in terms of pain relief. Yep. Again, I would say that's not normal. Would you agree with that?
I would agree with that. I think where the pain is affecting your quality of life, and quality of life, like you said, Claire, could be not ability to work and to study. Quality of life could be inability to have sex if you're wanting to have sex. It could be inability to exercise. It could be fatigue that's affecting you day by day. All of these things are not normal, and that's where you should start to look for help.
Great. And that's exactly the same thing to parrot to your GP as well. This is what my pain does. Yeah. This is the effect it's having on my quality of life. And, can you refer me to a gynaecologist to seek further clinical consultation? Yeah. Nice.
And in some centres in New Zealand, you can bypass the GP if you choose to, and that would be going straight to a gynaecologist. That would be privately. You can't, unfortunately, go straight to hospital for that. And the other final thing I would say is that for some people, pain is so intense and so unmanageable that you do actually need to present to hospital. And that is something that still should be encouraged. If you can't get on top of the pain and you're in a really tricky spot, even though it's very hard, you have to go to ED and get reviewed, because it could be something that's not endometriosis and actually way more acute, that needs reviewing straight away. Yeah.
So for the other person who is listening to this and they have been diagnosed and they're trying to decide if surgery is the next best thing for them, what would be the indications of that? Is this that they are trying the other things in terms of that maybe it's medication, or maybe the medication, while it might have improved their pain, wasn't fit for purpose because it had other side effects? Maybe it's that they've tried other complementary therapies and the pain is still affecting their quality of life, or being pain affecting their quality of life, or something else affecting their quality of life, like not being able to conceive. Is that who you would say is a good candidate to talk to about surgery?
Yeah, I think definitely if it's getting to that point, seeing a specialist, which is a gynaecologist, is a good starting point. And by all means, seeing a specialist to initiate pain relief, and medication options are also it's advised. But if you're wanting to start the process of an operation or a surgery, you'd need to be reviewed by a specialist, which can take time.
Right.
Yeah.
Okay.
And so start that early.
Yeah. And same thing for those that are like, if you're trying to conceive and you've got endometriosis, how long would you wait before you saw someone? Like, is this you would wait 3 ovulations before going to see someone, or is it sooner than that?
Yeah, that's a really good question. Often people wanting to get pregnant, it doesn't happen month 1, as a lot of people listening to this know.
And that's just normal probability, right? That's expected.
And where the pendulum swings towards abnormal probability is after 12 months. So I think after 12 months is where the medical suspicion starts to rise that, hang on, maybe there is actually something that's making it hard to get pregnant. May not be endometriosis, it may be something else entirely. But 12 months is when you should start to plan to seek more answers, do more investigations. And
is that even if you know you have endo?
I would say so. And
Right.
the reason I say that is that there are still a lot of people out there with endometriosis who get pregnant without any difficulties. And, mentally, because you have endometriosis doesn't mean that you cannot get pregnant. It may mean that the journey is a bit harder for you, but I would still say that giving it a good go for 12 months. That can also be varied depending on other factors such as age. So if you are older, generally speaking, over the age of 37, probably waiting 12 months is too long. And in that situation, I would say 6 months.
Right.
But for most people, I say 12 months, especially if it's the first time you're trying. Yeah. The probability is still higher that you will conceive in that 12 months. And if you haven't by then maybe there is something that needs addressing.
Right. Totally. And the same thing if you're like not ovulating at all, like because you might have PCOS. You're listening to this probably because you've got PCOS as well. So that could be a good time to, again, it's like maybe 2 birds, 1 stone. You're seeing that specialist and it's dealing with both the PCOS and the endometrio. Nice.
And certainly in my practice, of course, I can address some of the PCOS concerns with fertility, but exactly like endo, it's a niche topic, and so it might be that initial consultation, but sending you on to someone who does even more PCOS work for another opinion.
Nice. Well, thank you so much for talking to us all about that, Praveen. I think that's just amazing to have someone who's so specialised in this area who can give such a sage advice, especially about how to find someone and look for that right person to work with, how you would know you might need it, what's normal. I think that's really helpful as well. And just where to go if you need help. So thank you so much for sharing that with us.
Thank you. I really enjoyed catching up, and it was lovely to go through the topics we did. And always happy to come back if there's more feedback or questions from your listeners.
And how would those in Auckland or New Zealand find you?
So I work privately at Auckland Gynaecology Group in Auckland, and I'm happy to take self-referrals if you're interested for a conversation. We also do Zoom appointments for people outside of Auckland, and
Great.
so I'm always happy for referrals. Yeah.
Brilliant.
Thanks.
If you're finding value from these podcasts, then we'd be so grateful if you could hit follow on the PCOS Explained podcast. This means that not only you'll get the latest releases, but also that other people are more likely to find this podcast. That's the way the algorithm works. And we all know how important it is to get good information about PCOS. So if you can hit that follow button, it means that people with PCOS that don't know that this podcast exists are more likely to find it. So thank you so much for your help there. Now stand by for our disclaimer. The information contained in this podcast has been prepared for the purpose of providing information, including about the PCOS nutritionist products and services, and is designed to support clients' overall wellness. It is not intended to provide medical advice or designed to rectify, treat, or cure any specific medical conditions or diseases. Nothing stated or shared in our podcast is intended to be and must not be taken to be medical advice. Please seek the advice of professionals as appropriate regarding the evaluation of any specific information, opinion, advice, or content contained in our podcast.